Hello, everyone. It is really exciting to have over 300 participants from over 15 countries with us today. Good morning, good afternoon, good evening, ladies and gentlemen. We would like to extend a warm welcome to each and every one of you. My name is Zulmar Ali, and I'm the founding director of the newly established Brain and Mind Institute at the Aga Khan University. The Brain and Mind Institute's vision is to focus on mental health and neuroscience matters all across the geography served by the Aga Khan University through its 4 pillars of activities, namely research, education, innovation, and partnerships and advocacy. I would like to welcome you to Preventing Suicide in Pakistan, a webinar hosted by us in collaboration with Taskeen Health Initiative. The webinar will offer an overview of suicides in Pakistan, opportunities for suicide prevention by the state and civil society, and a discussion on overcoming the major challenges facing suicide prevention interventions. Our esteemed panelists include Ms. Anandaleeb Abbas, Federal Parliamentary Secretary to Foreign Affairs, Chairperson of the National Mental Health Task Force, Dr. Murad Musa Khan, Professor Emeritus, Department of Psychiatry, Aga Khan University, and the President of the International Association of Suicide Prevention, Dr. Rubina Kadwai, Clinical Psychologist, member of Sindh Mental Health Authority, and a Director of training at SECPAC, and Advocate Yasmin Aftabali, lawyer, columnist, researcher. We would like to acknowledge presence of Dr. Shireen Mazrahi, Federal Minister of Human Rights in Pakistan, as one of the attendees of the webinar. We are honored to have such a dynamic group of panelists present with us today. The moderator of today's webinar is Dr. Taha Sabri, an alumnus of the Aga Khan Medical College, a co-founder of Taskeen Health Initiative. Over to you, Dr. Sabri.
Thank you, Zul. Welcome everyone. Assalamu alaikum. Good evening. We'll start off with the questions. So the first question will be for Dr. Murad. So Dr. Murad, can you talk a bit about the prevalence of suicide in Pakistan and kaun si groups, kaun se demographics are sabse zyada affected in this country?
Thank you, Taha, and thank you, Zul, for inviting me to this webinar. Pakistan does not collect statistics on suicide either at the district, provincial, or national levels. So we have to rely on the estimates that the World Health Organization publishes every few years or so. The latest publication of estimates of suicide in Pakistan, according to WHO, of 2019, were that in Pakistan, 19,377 suicides took place in 2019. Now, this is an estimate. It might be an overestimation. And the research we have been doing and monitoring suicides in Pakistan, the figure may be a little less, but not considerably less. I believe it's probably anywhere between 10,000 to maybe 15,000. The WHO also gives a ratio for every suicide. There are at least 10 to 20 attempts at suicide. So these are people who attempt suicide but survive. And if you go according to that ratio, they're probably between 200,000, which is 2 lakhs, to 4 lakh attempts at suicide or self-harm in Pakistan. So this is the current picture. In Karachi, there are about 450 to 500 suicides. And this is again from various studies that have been carried out. And again, if you use the formula of 10 to 20 self-harm acts for one suicide, the number of self-harm in Karachi only would be anything between 4,000 to 5,000 plus every year. Now, the research that we have done at Aga Khan on self-harm and suicide tell us that most suicides in Pakistan are carried out by young people under the age of 30 years. And as you go up the age level, the number of suicides and the prevalence keeps on going down. And unlike the West, elderly are not more prone to suicide in Pakistan as they are in the West. So that's one major difference. The other major difference from the West is that when you look at female suicides and female acts of self-harm, then it's the young married females that predominate as opposed to single females. So again, this is again a very important difference we have found in Pakistan compared to the Western studies where marriage is considered as a protective factor. So those are the two, according to the statistic. The third important thing is that the three most common methods of suicide is hanging, use of pesticides or substances, and firearms. So pesticides, which include insecticides and other pesticides that contain organophosphates, in Pakistan is quite high, is the number two because of the easy availability of very toxic pesticides. And Pakistan is an agricultural country, so the pesticides are available freely. But also in the urban centers, in our homes, we have insecticides, to kill mosquitoes and flies and cockroaches and so on. So we have insecticides in our homes that also have organophosphates. Organophosphates are extremely lethal, and even a small amount if ingested can cause major problems, and that leads to a high what is called a case fatality ratio. There are other major differences also, but I won't go into the details, but because that will take up time, except one, that in Pakistan, two things really stand out as far as the causative factors are concerned. One is social factors play a very large part in the suicidal risk or to the person. Social factors: poverty, unemployment, underemployment, violence, and so on. And the number two thing is that depression, clinical depression in the suicide victims rates very high, up to as high as 90% in Pakistan, which is largely underdiagnosed and undertreated. So these are some of the major findings of suicide in Pakistan and differences from the West.
Thank you, Dr. Murad. That was very insightful. I would also like to welcome Ms. Andali Abbas, the chairperson of the National Mental Health Task Force and honorary federal secretary to Foreign Affairs. Thank you for joining us, Ms. Andali. We'll come to you shortly. So, Dr. Rubina, आप थोड़ा बता सकती हैं कि what are the major factors that are leading people to attempt suicide in Pakistan?
Thank you, Taha, for giving me the opportunity. So, Taha, just picking up, Dr. Murad ने अभी आपसे mention किया है जो उनका data उनकी study बताती है, and then also global studies बताती हैं. So, mental illnesses tend to be the leading cause. और एक स्टडी हुई थी जिसमें अमेरिकन, यूरोपियन, एशियन कंट्रीज का कलेक्टिव डेटा देखा गया था और कोई 3000 से ऊपर कंप्लीटेड सुसाइड्स में देखा गया था. तो उन्हें देखा था कि नंबर एक तो ये कि 87% ऑफ दोज पीपल जिन्होंने कंप्लीट की उनकी डायग्नोज्ड अनडायग्नोज्ड मेंटल इलनेस थी. और ये देखा गया कि जिसको मेंटल इलनेस होगी उनका 98% चांस है कि वो सुसाइड करेंगे. ये इस तरह है जैसे आप कहें कि हमें साइंस बताती है कि जो स्मोकिंग करते हैं उनकी 40% चांस है कि लंग कैंसर डायग्नोज हो सकता है. तो इसी तरह से जिन लोगों की मेंटल इलनेस है उनकी 98% चांस है कि वो खुदकुशी कर सकते हैं. उसके बाद आपके सोशल फैक्टर्स हैं जो डॉक्टर मुराद ने जिक्र किया. ये एक्चुअली बड़ी कॉम्प्लिकेटेड चीज़ होती है, ये 1, 2, 3 करके नहीं है, बिकॉज मैनी ऑफ द सोशल फैक्टर्स जिसमें शामिल हैं आपके domestic problems, marital problems, often connected to financial issues, unemployment, poverty. लेकिन unemployment, poverty बहुत से लोग सफ़र करते हैं, हर एक खुदकुशी नहीं करता. तो ये एक कॉम्प्लिकेटेड, लेकिन ये जब मिलते हैं और इनसे जहनी मर्ज होता है कि वो जो स्टेट होती है कि डेथ इज फ्रीडम फ्रॉम पेन, ये कोई नॉर्मल चीज़ नहीं है. वो स्टेट जिसमें इंसान कुछ कर बैठे वो एक शदीद ज़हनी बीमारी, शदीद आपकी एक कैफियत होती है जिसमें आप नॉर्मल इन स्ट्रेस से डील नहीं कर पाते. तो जिस तरह मैं आपको बताया कि लाइवलीहुड क्या है, तो सबसे बिगेस्ट इंडिकेटर जो है जहनी मर्ज होते हैं, उसके अंदर भी डिप्रेशन, कुछ साइकोटिक डिसऑर्डर्स और कुछ मेनिशियाट से मिलावस डिसऑर्डर्स, एंड बाकी जो आपको सोशल फैक्टर्स डॉक्टर मुराद ने बताए वही हमारे डेटा में भी दिखते हैं.
Thank you, Dr. Rubina. That was very insightful. So, Ms. Andili, I'll come to you now. आप थोड़ा बता सकती हैं about the recently convened National Mental Health Task Force and what is its current focus?
Ji, thank you so much, and it's really a privilege to be present among such learned people, especially the medical fraternity. I'm not a doctor, but I also am very much interested in behavioral and mind sciences. So my background comes from the fact that the most important and the most powerful machine on the earth or universe is the mind. And it's so powerful that it can go beyond your expectations either way. If it's positively channelized, it can, sky is not the limit. If it is negatively channelized, then as you are talking about, that self-destruction is very high. So my interest in this subject, when I was a behavioral science student, and then I did certain certifications in it, and I became a behavioral science coach. So when I came into the government, I was very interested because I had been associated with the field of teaching, and I saw in the younger generation, and that's my biggest fear, I saw a generation which was very bright, very smart, very talented, excellent on smartphones, but zero on interpersonals, zero on emotional intelligence, zero on so many other factors. And it was leading at that time to a growing, almost epidemic of unrest, low self-esteem, and depression at a very early age. So I become the chairperson of the National Mental Task Force, because if Pakistan has to change, and that's what our government wants and I want, then the mindset has to change. And sometimes I say that the mind is, it should be the other way around, set mind. Minds are so set at home, in the government, in the National Assembly, in the offices, in academics, in classrooms, that trying to make people see differently becomes almost an impossible task. So and I saw some statistics that almost 70% or more than that, the mental depressions and the suicides take place between the age of 18 to 40. And that shows that a lot of our younger generation is not being listened to, not being addressed to, and it is leading to, as my honorable colleague said, to drug addiction, to violence, to unrest, to suicide, to conflict, to lack of productivity. I mean, all studies, when I was doing the corporate behavioral science things, all studies show that disengaged people cost 75% of productivity. So you have a person coming in, वो बैठा हुआ है, काम कर रहा है, लेकिन वो नहीं है, क्योंकि उसका दिमाग नहीं चल रहा. उसने कंप्यूटर खोला हुआ है and he's got a mental block. And there's all sorts of violent thoughts, all sorts of negative thoughts going on, and they are giving so much stress and pressure to him that either it comes out in the fight, lack of productivity, lack of work, in the office or at home, relationships are suffering. और मेरा ख्याल है कि जो ये सोशल मीडिया ने ना ये काम और खराब कर दिया यंगर जनरेशन में.
Sure.
And I've written a lot on it. मैंने कोई स्टडी नहीं की, but social media gives you a chance of living in a fantasy world. Facebook is a face which is not your face. So you put in a picture of yours as having the greatest time in the world, and वो peer pressure से देख के इसकी जिंदगी कितनी अच्छी है, he's having a bang of a time, she's having good relationships, she's going there, here. वो आप एयरपोर्ट में भी बैठे होते हैं तो आप अपना वो मैप लगा देते हैं, sitting here having coffee. तो वो इतनी ज्यादा हमारी एक आर्टिफिशियल सी वर्चुअल लाइफ हो गई है कि जब वो रियलिटी के साथ उस यंगर जनरेशन को they have to come in sort of touch with the reality, they're not able to adjust, they're not able to adapt, they're not able to change.
Very true. And that's so important, Ms. Andalip, all of these points. So did that lead you to form the mental health task force? Is all of this a motivation behind this pioneering initiative on your behalf in the government, the National Mental Health Task Force?
You see, if Pakistan needs to develop, its younger generation needs to be putting in their best energies. And it's older generation also, and it's mind over body. So if 43% people in Pakistan are depressed, and 80% of non-communicable diseases are also being spurred on by bad mental health, because we all know whether it's cancer or it's anything else, somebody who has a strong mind will recover, somebody who has a weak mind with all the medicines will not recover. So mind over body is my motivation. If mind is the most important thing, then in the government priorities, unfortunately in 74 years, it has not been a priority. It's for the first time that the president and the prime minister are taking it right at the top of its list of what should be done to make the Pakistani mind, which is so talented, happy, well, and being able to put its best.
Thank you so much, Ms. Andalip. It's great to see such visionaries as yourself as part of the government who recognize this such an important issue. So thank you, and we'll also come back to you and ask about the government initiatives on this. So thank you for that. So how does Pakistani law look at suicide? थोड़ा बता सकती हैं कि according to our constitution, according to our laws, penal codes, like how is suicide looked at, and थोड़ा इसके बारे में वजाहत अगर आप करें तो that'll be great.
Thank you very much, Taha, and members of your organization for having me here today. जहाँ तक क़वानीन का ताल्लुक है या suicide का particularly, see, when we look at our laws, whether it's constitutionally or under its umbrella, the lesser laws, because constitution is your mother law. It can be the behavioral attitude of a person which is governed by different laws, can be divided into two clean sets so far as Pakistan is concerned. एक आपका Sharia law है, जो आपके personal, जो आपका फ़िक़ा है या मज़हब है उसको govern करेगा. इसमें आपका इनहेरिटेंस लॉ आ जाएगा, उसमें आपका गार्जियनशिप का कानून आ जाएगा, मुख्तलिफ कवानीन आ जाते हैं. इस मर्डर, अटेम्प्टेड मर्डर, सुसाइड, यू नेम इट. दूसरा कानून वो है जो हमारे बिहेवियर को तो गवर्न करते हैं, मगर वो ऐसे कवानीन हैं जो जनरल हैं, फ्रीडम ऑफ एक्सप्रेशन और फ्रीडम ऑफ स्पीच को ले लीजिए. लेकिन उसमें जो एक्सेप्शंस हैं, those are particular to every country. Some are universal, जैसे defamation, उसमें slander और libel है, contempt of court है, जो हमारे यहाँ आर्टिकल 204 बताता है. अब important चीज जब आप इन कवानीन को देखें तो ये है कि in every law there is an exception. आपको behavioral law कोई उठा के मुझे दिखा दे जिसमें exception ना हो. मिसाल के तौर पे एविडेंस एक्ट जो है, जो दो औरतों की गवाही और एक मर्द की गवाही की लोग बात करते हैं, it is often misquoted legally. What it says is that if a woman, if is heavily underlined, forgets a particular financial transaction, exclusively financial transaction, she may May is an option, it's not mandatory कि वो किसी दूसरी औरत से पूछ ले. अब ये एक्सेप्शन आ गया क्योंकि पहले खवातीन एक्सपोजर नहीं था, पढ़ी लिखी नहीं थी इस तरह. आप आर्टिकल्स 19 देख लीजिए, फ्रीडम ऑफ स्पीच और फ्रीडम ऑफ एक्सप्रेशन, a list of exceptions are running there. आप आर्टिकल 62 और 63 देख लीजिए कि कौन इलेक्शन लड़ सकता है, एमएनए और एमपीए का, कौन नहीं लड़ सकता. लिस्ट ऑफ एक्सेप्शंस रनिंग there. अब आप सुसाइड और मर्डर की तरफ आइए. जो कत्ल का मामला है वो मुझे समझ आ सकती कि गुस्सा है, खानदानी झगड़ा है, जमीनों के झगड़े हैं, औरतों और ऑनर के नाम पे किलिंग्स हो जाती हैं, पैसे के लेन देन पे किलिंग्स होती हैं. लेकिन उसमें भी सेक्शन 306 ऑफ पीपीसी विल टेल यू कि किसास अगर दिया जाए ना, किसास और दियत का कॉन्सेप्ट एक शरे से, हमारी अपनी शरिया से आता है. वो अगर दिया जाए तो अगर कोई इंसेन है या माइनर है तो उसकी एक्सेप्शन आ रही है वहां पे कि उसके लिए क्या चीजें आपको देखनी होंगी कानूनी तौर पे. इसके अलावा 306 एक बड़ी इंपॉर्टेंट बात हमें बताता है कि अगर कोई इंसेन है तो क्या कोई अमल करते वक्त was there a sustained period of lucidity over there when he or she committed an act. So law is very clear on many of these things. Suicide इस्लाम में गुनाह है. अगर आप शरिया को देखें, इस्लाम में कहीं उसकी सजा नहीं है. Nowhere in your religion does it say that it is an offense which is to be punished. It is a guna.
Then where did this law come from? Advocate Yasmin, this section 325, where did it come from?
It came from the British law, which we inherited. UK, चूंकि हम गोरों ने हम पे हुकूमत की, हम आज तक गोरी चमड़ी के काफी गुलाम रहते हैं, फख्र महसूस करते हैं इस बात में. So there have been changes in the constitution where, and if required, mostly for the benefit of politicians, मगर जो general societal improvement है उसके changes आपको कम मिलेंगे. देखें, I believe people are not for the laws. Laws are for the people. The society.
Excellent. Thank you.
Society
That's an excellent
changes.
point.
जी बिल्कुल. माशरे में देखें, अब जितनी ड्रग्स हैं, जितने मसले हैं, वो हमेशा रहे होंगे, मगर आज से 50 साल पहले शायद इतना ज्यादा ये मामला ना हो, which has compounded a lot of issues. Now, religiously, no, Islam does not say कि इस शख्स ने खुदकुशी की कोशिश करी तो इसको तुम सजा दो या फाइन करो या जेल दो. देखें, बहुत मुश्किल काम है अपनी जान लेने की कोशिश भी करना.
So I think that's an excellent point you've raised, that essentially this law is a British law.
One point, if you would allow me. I have been working in the rehabilitation centers as a volunteer for many, many years. I've been going to Qasum. I've been dealing here. I've even arranged raids when I knew कि वहाँ पे drug चल रहा है और ये सब हो रहा है. But you see, one thing that I saw was that people under drug effects have the same signs or symptoms as the psychotic patients. As a किसी को अगर schizophrenia है या depression या कोई और दूसरे मामलात हैं, दवाइयां वही हैं जो दोनों को treat करती हैं. और वो एक लम्हा होता है डिप्रेशन का, एक कमजोरी का लम्हा, जब वो बंदा कर जाता है अपनी जो उसके जहन में एक उस वक्त चीज आई होती है. So I remember when I was a student, our law teacher would tell us that please, if you want to attempt suicide, ensure you succeed, because if you don't, then you have to face the law if you don't succeed.
So sad. I think so poignant, and आपने जो बात की है, and it is so sad that there's a law which is preventing people from getting help. So I think that, and we'll come back to you, Advocate Yasmin, about later, what are some legal options that can be used. But so we have a short video now of a survivor of a suicide attempt which I think would really enrich this conversation. So I'm just going to share my screen and show that video.
तो मैं अपने ए लेवल्स में थी, मेरे ग्रेड्स कोई इतने अच्छे नहीं आए थे। फिर उसके बाद जो उसकी वजह से मुझे गैप ईयर लेना पड़ा, उसकी वजह से मेरी मेंटल हेल्थ बहुत ज़्यादा इफेक्ट हुई थी। और जब मुझे पैनिक अटैक्स आना शुरू हुए तो एकदम से आते और मुझे समझ नहीं आता मेरे साथ क्या हो रहा है। हम लोग एक कराची का बहुत बड़ा प्राइवेट हॉस्पिटल है, उधर गए। उधर से जो उनका जीपी था उससे बात की, तो उसने बजाय कि वो किसी मेंटल हेल्थ ऑर्गेनाइजेशन के बारे में बताता है या कहता है कि इट्स मोर ऑफ अ साइकोलॉजिकल इशू, उन्होंने मुझे कहा कि इनको तो एस्मा है और साथ में एक पंप पकड़ा दिया। तो फिर एक दिन मेरी मेंटल हेल्थ इतनी ज़्यादा ख़राब हो गई कि मैंने घर में स्लीपिंग पिल्स रखी थी। मैंने जेनिक्स होती है स्लीपिंग पिल, मैंने फोर्टी 50 के अराउंड खा ली और नीचे गिर गई। फिर उसके बीच में मुझे याद नहीं क्या हुआ। फिर हम एक प्राइवेट हॉस्पिटल गए, वहाँ पे उन्होंने मेरा जो सिस्टम वगैरह था उसको क्लीन किया। तो उसके बाद ये हुआ कि पुलिस वाले हमारे घर आ गए, हमसे बैठे थे, पुलिस वाले आ गए। उन्होंने कहा कि हॉस्पिटल वालों ने कंप्लेन की है, आपके घर में किसी ने सुसाइड अटेम्प्ट किया था तो इसकी सज़ा होती है। तो पापा के साथ स्ट्रगल हुई, सब कुछ हुआ। उन्होंने कहा अगर आप नहीं जाएंगे तो पापा ने कहा क्योंकि हाँ इसकी ग्रेड्स वगैरह खराब आए थे तो उस वजह से जो है ये बहुत परेशान थी। तो उन्होंने कहा देखिए सज़ा तो मिलेगी, या तो आपकी बेटी को मिलेगी या आपको मिलेगी। तो फिर जैसा पाकिस्तान का सिस्टम है, हमने उनको उन्होंने खुद ही उस चीज़ के लिए ऑफर किया है कि आप ड्राइव दे के यू कैन गेट अवे विद दिस।
So I think that was a very moving story, and now I'd like to go to Dr. Rubina. So Dr. Rubina, based on your experience, what are some suicide prevention interventions that can be effective on a population level हमारे मुल्क में?
Okay. सबसे पहले तो first thing is awareness that suicide is most often an indicator of suffering mind and mental illness, not just average person suffering, but in mental illness. Number two, it's so preventable. Suicide is 100% preventable. It's citizens of any country dying through a death which is preventable. And and one thing that I think I know you and many of us are pushing for is this. It becomes difficult to talk about this, difficult to address it, difficult to collect data as long as this is a crime. As long as this is a crime in the country, there are no numbers, there are no registries. Look at how they're managing COVID. There's registries, they know which area to go to, they know kahan zyada hai, kahan kam hai, they're developing preventive measures according to that. But we don't know how many citizens were losing to suicide. So I think many factors. One is we need to have more awareness. We need to really repeal this law that's a huge deterrent in people getting help, in families reporting it, a huge deterrent. It's an obstacle to collecting data. We can't have any policies for prevention and for promoting health. Lawyers don't know about it, police doesn't know about it. So I think a general awareness. And I think Yasmin just touched upon it so well, Advocate Yasmin, that in our culture, interpretations of our religion is also a deterrent, because Yasmin pointed out so well, people tend to have very mixed feelings about this whole idea. But I think the scholars can come up front also. There's so much room in our religion for people who are not well. And there's one thing I want to say, I think Yasmin, you may also again talk about this more. There's section 84 in Pakistan Penal Code, I believe, that really talks about anyone who's done anything when they were not in sound mind cannot be held culpable for it. So I think you asked me about what to do about prevention. So I think awareness raising, repealing the law, which will help us collect more data, people come forward, setting up helplines, but that'll only happen if it's decriminalized. You decriminalize it, then you set up helplines, because we're thinking decriminalize it and prevention. So collect the numbers, collect the data, know who's at risk. And there is information, there's knowledge. And so once we have data, we can know, how can we protect this group? What are the risk factors? Who to target more? And again, I'll keep coming back. ये पाकिस्तानी है जो एक preventable death के हाथों खत्म हो गए और इतना कुछ क्लियर कट है और बहुत से मुल्कों मुस्लिम मुल्कों ने कितनी एडवांसमेंट्स की हैं we can learn from them, we can just look at them ने क्या steps लिए हैं कि हम भी उसी direction में जाएं. I totally think this we're heading towards a new country, a new Pakistan, and what better way than to celebrate life. It's a really easy step that other countries done. Easy in the sense कि clear cut है, करना मुश्किल है, but it's a science now. We have knowledge, we know steps that can be taken towards it. I hope I've answered your question.
Beautiful sentiments, Dr. Rubina. I think very, very well put. And I think Dr. Murad ke paas ab aunga ke, so Dr. Murad, Dr. Rubina talked a bit about criminalization in Pakistan, and Advocate Yasmin also added to that. And we also saw in the video the survivor, the trauma she experienced because of the criminalization. Of course, not prosecution, but the harassment and all of those things. So, and we know that recently you've worked on a report, a global report on suicide criminalization. Can you speak a bit about that? Okay, globally, in how many countries is suicide criminalized, and sort of like a bit of the characteristics of those countries, and the effect that it's having on sufferers, this criminalization?
So, as far as we know currently, there are about 20 countries in the world that suicide or suicidal behavior is still criminalized. And these include 3 or 4 Muslim majority countries: Bangladesh, Pakistan, Qatar are amongst them. There are countries in Africa. Ghana is one of them. Kenya is another. There are countries in South America. Guyana is one of them. Saint Lucia is another. And then there are countries in South Asia, like Malaysia, for example. So there are 20 countries in which it's still criminalized, and the punishment varies from 1 year to 3 years of jail imprisonment. And in countries like Pakistan, there's also a financial penalty. There are another 20 countries which are Islamic countries that follow the Sharia law, and although it is not criminalized under law, but according to the Sharia, people can be punished as well. So that's the global picture. I need to add here that from the religious point of view, from the Islamic point of view, it has been condemned in Islam because it becomes a deterrent for people not to try and interfere with God's work, because God is the only one who can give life and take away life. And there is a time appointed for everyone to die, and man should not interfere with that. आपने पूछा था सवाल कि where did this law come from? A lot of Muslim scholars in the olden days, they interpreted the injunction against suicide in Islam to apply to attempted suicide. Islam does not say anything about people who attempt suicide. It only says, do not die by suicide. It's very important to make that distinction. But what people have done, they have taken the completed suicide and have applied it to attempted suicide. And so people are therefore prosecuted on this. In Pakistan, at a practical level, very few people are actually prosecuted. Very few people, the very few people against whom an FIR is registered, which is according to the law. If you do anything which is against the law, very few people undergo prosecution. But what happens is this law is being used by the authorities, the police, the medical legal officers, to extort money and bribe patients and the victims and the families. And this happens very commonly. So one of the important reasons why it should be decriminalized, apart from what Dr. Rubina and Ms. Andalib has said, is that it will stop people from being harassed. That's very important. And a lot of them undergo a lot of lot of mental torture. And I know of cases where they have been giving a regular allowance to the police because the young girl had made an attempt, ended up in Jinnah hospital, and the police then threatened them that we will register an FIR. And therefore, the parents kept giving the allowance for many, many years. And so it is happening across Pakistan. So that is also a very important reason why it needs to be decriminalized. I just one very quickly make a point that I did not when you asked me the first question about statistics. In Pakistan, suicide and self-harm acts take place in every district, every province, and every part of the country. No ethnicity, no ethnic group, no linguistic group is exempt from that. And the highest rate of suicides, if you look at male, female, young, old, everywhere, the highest rates of suicide is in Gizar, in Gilgit, in Pakistan, in young females. That's number one. We have just completed a study in Malakand, in KP, and it's a conservative province. You know that KP as a whole, and you wouldn't expect Malakand to have these suicidal acts, but you'll be surprised. They were in about 5 years, almost 2,000 acts of self-harm, of which about 5% were fatal. And most of them were registered. 80% were registered as self-harm under the Act, but very few were again prosecuted. So it's important to not to look at suicide as a universal problem. And like Dr. Rubina said, most suicides are preventable. The vast majority are preventable. And if we have good mechanisms, good processes, and good research to back that, good science, then and good programs, then it can actually, majority of them can be prevented.
Thank you, Dr. Murad. That was very insightful, and especially the bit about Malakand and Gilgit-Baltistan, which are places you won't expect where this would be a problem. Ms. Andali, coming back to you. So what efforts can be taken by the National Mental Health Task Force for suicide prevention? And आपकी नजर में, especially जो suicide decriminalization है, जो law है, उसके खिलाफ what can the current government do? So that's also a question from the audience.
Okay.
Deciding that. So we would love to hear your perspective.
Okay, so there are basically three major aspects that need to be dealt with. One is, of course, the stigma attached to it, and suicide, the idea of opening up the discussion. Like, for example, drugs and drug addiction is a stigma. Nobody wants to talk about it. We tried to make a law that drugs should be tested in schools on students. Everybody rebelled. Schools didn't want this to be revealed. Parents didn't want this to be revealed. And so there are barriers to make laws also, because if you make a law and there is resistance, it's not going to be implemented. But we are making certain changes in the law to be able to do something which is not that offensive. So first is open the dialogue. Let people talk about suicide awareness in schools, in colleges. We are also trying to have counselors over there of mental health. So it's overall mental health, and obviously suicidal thoughts would be, so they should be trained. The problem is that I was shocked to find out that in the whole of Pakistan, you just have 600 psychiatrists. The whole of Pakistan. And people who are trained in this field, counselors, etc., negligible. So we have to have, and we are doing that. We are creating a training of the trainer through videos, through that. We are doing that. Second is that we are opening a helpline, and that is for mental health. So that the helpline will be connected to various, specialities. If you want to talk about mental health or depression or abuse or whatever. So there will be people to help you initially and redirect you. Third, very important part is that when you talk about mental health is that parents' attitude, counseling, and awareness. Very important. Not just so So parents, I know there are students who have mental health problems, and parents just feel that they are shirkers, and they are, you know, even if they know that their children are showing signs, they are in denial. So they do not address them at the right time, just by talking sometimes, because suicide ideation starts way before suicide happens. So by talking, giving empathy, compassion, social help, a lot of these ideas can change. So parents need to be counseled as to what are the signs. How do you address them? I mean, there was a famous story, you must have, very, very touching story of two parents who had a son, Imad, if you remember, about in 2018, it came in all newspapers, that they had a brilliant son, Imad, who had gone to America for further studies. He was smiling, he was okay, he never showed any signs, but he committed suicide. And then later they found out that he was an A grader, but he was not A plus. He was a great coach, but he was not the best. And inside, he just felt like a failure, and he never expressed it. The parents didn't notice it. And one day he just said that, you know, it's not worth living. And it was such a trauma and shock to the whole family. So we need to address parent counseling, and we are trying to develop, frameworks for that. And of course, the funding and research, the research is not enough, funding is not enough, human resource availability is not enough. But for the first time, a discourse has started in the highest level, in the ministries, and I think that is where, if you really want the government to help you, it has to believe that this is the root cause of all other illnesses, and that's there. So in the Ministry of Health, with our advisor, Dr. Faisal, we have, in my sort of mental health task force, we have, Dr. Rizwan Taj, who's heading PIMS, so many others, and they're all giving their, input into the awareness aspect, the treatment aspect, and the legislation aspect. So basically, that's what but there's a long journey. And I'm telling you that for the next 5 years, we'll keep on hearing the government didn't do anything, nothing has been done. But the journey always starts with the first step. And yes, we are trying to develop a helpline. If that also develops and we create an awareness for it, and we target a few academic institutes as pilot projects in Islamabad, I think that itself will be an achievement.
Excellent. That is so lovely to hear, Ms. Andaleep. Thank you so much for the input. And we'll also take some questions from the audience after this question from Advocate Yasmin. Advocate Yasmin, it'll be great agar thoda bata sakti hain about what are some legal options that can be taken to decriminalize suicide, to address this problem by the government, and what are some risks associated with them as well. So it'll be great agar thoda iske baare mein aap ek perspective de paएं.
देखिए, इसमें दो ऑप्शंस हैं जो हुकूमत ले सकती है. पहला ऑप्शन ये है कि कोई एक्सेप्शन मौजूदा कानून में पैदा कर दी जाए. So when a person tries to commit suicide and survives, because you cannot penalize a dead person anyway, तो उसकी जांच के लिए कि उसने किस ज़हनी कैफियत में ये किया, a panel of doctors, it can be a mix of psychiatrist and psychologist, और वो एक उसको जांचें कि क्या उसका frame of mind था, उसका background क्या है, is he on some medication, is he a depressive maniac, is it something that has gone undetected for years. But you see, the problem in such a situation is that when with the high level of corruption, reports can be manipulated, families can be blackmailed, और वो अपनी इज्जत के लिए या बच्चे के लिए या whatever multiple reasons, they may end up paying extortion money kind of thing. So that's not a great idea. How I see it is basically that this law itself is outdated. it needs to be booted out. It needs to be struck away, because जो suicide patients होते हैं, जो बच जाते हैं, अव्वल तो जो मर गए, तो पहले से उनके लिए एक compassionate empathy, जिस तरह मुझे बहुत अच्छा लगा अंदलीब साहिबा ने जो बताया ये हेल्पलाइन का, that's I think that's a great idea actually. If it can work out and it can help people, it should be great. मतलब आप कोई फोन उठाएं और आपके पास नहीं है कोई, आप किसी बाज़े औक़ात अपने से बात नहीं कर सकते, there are reservation, पर्दे हाइल होते हैं, बच्चे या दूसरे लोग समझते हैं कि घर वाले हमारे मसले को नहीं समझेंगे, और बहुत दफा ये होता है. I've seen this in my own experience of working with such patients. लेकिन उसमें जो चीज इम्पोर्टेंट है कि जो चीज रुक सकती है, जैसे डॉक्टर किदवाई ने भी कहा, उसको रोक लिया जाए. और अगर खुदा ना खास्ता कोई अटेम्प्ट कर ही लेता है, तो वो इस किसी के हाथों ब्लैकमेल ना हो, उसको फिर एक मेडिसिनल तरीके से मोहब्बत के साथ उनके मसले को देखा जाए, ना कि ये कि उनके ऊपर इल्जामात की बौछार और उनको पुलिस का मुकाबला करना पड़े. And you know that can be not only traumatic and self-defeating for the family, but also for the patient concerned. So the best thing that the government, if it really wants to look at this thing compassionately, ये कानून जिस मुल्क से आपने लिया वो तक निकाल चुके हैं, तो हम क्यों लेके बैठे? I mean, can you please come into the 21st century over here?
And of course, I think that it's an excellent point. Of course, this law has been there for 70 years, but this government has an opportunity to address that.
Absolutely.
Thank you so much, Advocate Yasmin. Thank you so much. So I think we have a lot of questions from our audience, so we'll be moving to that. I think the first question is an anonymous question from for Ms. Andali. So the question is that the current mental health task force is an excellent initiative, but it's dominated by psychiatrists and from the northern part of Pakistan. How can we make it more representative? How can we include psychologists, public health professionals, to make it more multidisciplinary and to make it more representative nationally? So that's a question for Ms. Andali.
So actually, it's not just by psychiatrists. We have 3 technical committees. One is awareness in education. And we have people from marketing, people from media, people from the television industry, people from the research background. Then we have legislation enforcement. We have people from the government, from the anti-narcotic force. Then we have people for treatment rehab. We have people from the psychiatrists. We have people who are working in rehabs. So there's a lot of that. Obviously, I still feel that the task force should be very limited. And in my opinion, we are still a little too many. What we have suggested is that all these 3 technical committees can co-opt and get various people in as they go along in the journey. And yes, it's always good to have diverse opinions, and we will be taking diverse opinions. But the problem with committees is that sometimes I feel these huge, large committees, when there are too many, they keep the minutes and they waste the hours. So that's the problem, because everybody wants to pool in ideas, and which is excellent, but very little work gets done. So what we've done is we've divided, given tasks, and we've said you can co-opt whomever you want to.
Excellent. Thank you so much, Ms. Andali, for that point. So next question is for Advocate Yasmin. What can ordinary citizens do, if anything, to help repeal Section 325? So for Advocate Yasmin, yes.
देखिए, बहुत सारे ऐसे फोरम्स हैं जिनको आप ज्वाइन करके, जैसे आपका फोरम है, you have been working for it, and you guys have come at a point where your voice is being heard. तो कोई इनिशिएटिव्स इस किस्म के लिए जाएं ऐसे इदारों के साथ मिलकर, कि जिससे एक आवाज, जब बहुत सारी आवाजें मिल जाती हैं तो वो एक बड़ी आवाज बन जाती है. And then people living in different areas as well can maybe form their own groups. They can be as formal or as informal you want it to be. कि वहां पे आप कोई अपने awareness programs लोकली मिलके कोई प्रोग्राम्स, कोई आर्टिकल्स लोग लिखते हैं, लोग कोई ब्लॉग्स करते हैं, कोई लोग टिकटॉक पे हैं. आजकल तो अपनी आवाज सुनाना सोशल मीडिया के थ्रू रिलेटिवली काफी आसान है, जो पहले फॉर्मल मीडिया की लाइफ में और इनफॉर्मल मीडिया की गैर मौजूदगी में इतना आसान नहीं था. And they can get in touch. For example, जैसे मेरे आर्टिकल्स जब भी लगते हैं तो my email address is always there, my Twitter handle is always there. इसी तरह और लोग भी करते हैं, तो उन लोगों के साथ आप in touch होके you can work among groups locally as well as other organizations and people working for this.
Excellent. Thank you so much, Yasmin. So the next question is for Dr. Murad. So the question is that a lot of psychiatrists, they tend to focus on medication management rather than counseling and therapy. And why do you think that is? And what kind of damage may that be doing? So Dr. Murad. Yeah.
So psychiatrists come through a medical school background. And in medical school, the emphasis is always on diagnosis and treatment. And the treatment mostly is biomedical treatment, which is either a procedure if you're in surgery or medicines if you're non-surgical. So, and then psychiatrists go and train in psychiatry. And with that background, they tend to have this leaning towards the biomedical model. The training on psychotherapy, counseling has a very small portion, particularly in Pakistan. There's virtually very almost nil in psychology and biomedical things. So that's one major impediment. The other is the time it requires to counsel a patient. Psychiatry is time intensive. If your earning comes through seeing patients, and the more number of patients you see, the more you learn, then you want to have a large number of large practice. And to do that, you've got to then get the patient out and get the next patient in. And writing a prescription is the easiest thing to do so, rather than listening to the patient, then counseling the patient, which takes a lot of time. So it is not just the psychiatrist, but the health system that they work in also has to be taken into account. And both things have to be there. Ms. Andaleep said there are only 600 psychiatrists in Pakistan. It's probably less than that. It's closer to 500. And the question we have to ask is, why are there so many more psychiatrists in North America and the UK? Current total is about 1,700. Why there are only 500 or 600 in Pakistan? And the absence of a good mental health system and the absence of a career structure, and then the general conditions in the country make people leave the country and not come back. So it is not simply a question of psychiatrists prescribing medication, but you've got to take a holistic view of what is the system that they work in, which makes people see patients quickly, get them out, and therefore prescription becomes an easy way of treating it.
Thank you, Dr. Murad. I think that's a very insightful point. So, Dr. Rubina, I think this question was great for you. That what do you think is the utility of peer support for parents, victims, youth in recovery? Like how, like are there examples from other countries in which, aside from professional support, peer support has been utilized? So, can you speak a bit about that?
Yes, absolutely. I'm not aware of numbers, but I am very familiar with such programs, and they are, they're less resource intensive. It's a great resource, especially in a country like ours. Aap koi si minimal unki training.
Can you also speak a bit about what peer support is for the benefit of the rest of the audience?
Okay, so two ways you can look at it. One can be, people who have been through that experience and they were resilient enough, and they were at a time suicidal, but they came out of it. They were resilient, and they're sort of an example for the other person. Look, I've been through, and they guide them. The other angle of it is families, friends, community leaders, and community workers that you can train in basic listening skills, basic support, and so it doesn't take much. Take a few 10, 12 days trainings, and if you have a place to go to where you feel safe and you can talk. Early on someone just said कि वो एक छोटी window होती है जब इंसान और सुसाइड करते हैं, लेकिन बहुत टाइम उसके ऊपर वो सोचते हैं, एम्बिवेलेंट बहुत होती है, बहुत अरसे एम्बिवेलेंस होती है, एंड देन कम्स अ लिटिल विंडो जब वो कर बैठते हैं। तो जब वो एम्बिवेलेंस होती है ना, शुड आई लिव, शुड आई डाई, शुड आई लिव, शुड आई डाई, इस किस्म की एम्बिवेलेंस के वक्त मौजूद हो नॉन जजमेंटली सुनने के लिए, तो वो विंडो गुजर जाती है। हम थेरेपी में भी यही करते हैं। जब थेरेपी में हम किसी सुसाइडल इंसान से बात कर रहे होते हैं, हमें पता होता है कि हमें जब वो विंडो पे है कि वो एक्टिवली जान लेने वाले हैं, हमें उन्हें एम्बिवेलेंस पे ले आना है वापस, हमें उसमें बिल्कुल ऑपोजिट नहीं जाना है। If they come back to the ambivalence कि हाँ नहीं शायद, that's a safer place. So peer support ये होता है कि वो स्पेशलिस्ट नहीं होते, मेंटल हेल्थ प्रोफेशनल्स नहीं होते, लेकिन आम लोग हैं जिनको आप बेसिक, और फिर आप फैमिलीज को इंफॉर्मेशन दें कि साइंस को पिकअप करें। जब कोई बहुत विड्रॉ हो रहा है उनसे बात करें। अगर कोई इशारे दे रहा हो कि इशारे के नाम में कि मेरी जिंदगी बेहतर होगा जब मैं चला जाऊंगा, चली जाऊंगी, इस चीज को पूछें, बात करें, वो स्पेस दें कि बंदा बात करे, क्योंकि बहुत दफा साइंस होते हैं जो हम लोग मिस कर जाते हैं।
Sure. Thank you, Dr. Rubina. So I think we're going to now be wrapping up the webinar. And for this, I think if the panelists can just, in one sentence, their final thought, it's very tough, but in one sentence, this is the final thoughts that they have. So if Miss Andali can go first, that just one sentence, what are some final thoughts that you would like to share with our audience today?
So 80% of the battle is here. You fix here, everything else will be fine. And that's why God has put the mind first over here and then the body. And that's how medical, legal, political, every priority should be developed.
Thank you so much. That was great. Advocate Yasmin, one sentence from you.
Legally, I think that this law needs to put away the criminalization aspect, and it should be 100% focusing on compassion and medicine. And that can only be done if this law is struck down.
Excellent. Thank you so much. Dr. Rubina?
Thank you, Taha. My thought is ये कि we know हमारी 65% population young population है, youth population है. Suicide numbers है हमारे पास सिंध में 10 साल के और 18 साल के लोग ही suicide कर रहे हैं. ये हमारी potential है, इसको बचाना इतना ज़रूरी है, और इसके लिए one thing we need to do, the first thing we need to do of the many things we're going to do is to get rid of this act, this law.
Thank you, Dr. Rubina. Dr. Murad?
So while the law is being addressed and hopefully suicide will be decriminalized, it is important to remember, and someone asked this question also, what can we do at our levels, at individual level? It's important to remember in suicide prevention, jitni bhi theories hain, jitni bhi plans hain, the first line of defense against suicide are family and friends. Because family and friends are the ones who know the person, and if there's any change in one's behavior, they will be the first one to pick it up. So first line of defense is family and friends, and it is not the professionals. And the number one suicide prevention strategy, and there are many strategies that WHO recommends, there are 11 different levels and so on, but the number one suicide prevention strategy is connectedness. No one dies by suicide in public, it's in isolation, because they feel no one understands them, their problems are only with themselves, and if they take themselves out of the equation, then they won't have to face this. So connecting with another person, not leaving that person on their own, finding out how they are, not leaving him or her alone is the number one suicide prevention strategy. So we need to become more compassionate. We need to become more humble. We need to become more gentle with ourselves and with the others. And that's how you reach out to the others and not make them feel isolated in a time of crisis.
Thank you. Thank you, everyone. The final, I will invite Zul to Dr. Zul to close the webinar, share some final words of wisdom. Please, Zul. Yeah.
Thank you very much. I think that it was a very exciting dialogue, and it is so important that we talk about these issues. I think we're talking a lot about compassion. We're worried about our youth, and I'm so excited that Ms. Andalib is taking charge in leading the task force to kind of address the issues of mental ill health. And I think if we address all these components of compassion, of legal issues, of service provision, access to care, and about the connectedness, as Dr. Murad was just talking about, I think that we would be in a very good stead for our country, because I think it's important not only socially, but it's important economically. It's important for our next generation to be coming to the full fruition of their capabilities. And I think if we don't address the issue of mental health, I think that we're doing them a disservice. So I'm very happy that we've had an open dialogue on this matter. It's a sensitive issue, but if you don't talk about it, nothing happens. So let's kind of work together and see what we can really do for our people who are suffering in silence. Thank you very much, everybody.
Thank you, Zul. I would like to thank our panelists, Dr. Murad, Advocate Yasmin, Dr. Rubina, Ms. Andalib, and I would like to thank the audience and of course Adi Khan Brain Mind Institute for co-hosting this with us. And we will have other panels discussions as well. And if you have any other questions, you can email us on the designated email address, and we will be sure to get back to you. Thank you, everyone. Have a great evening. Allah Hafiz.